Good morning and welcome to this live case transmission that will be done this morning from the host center, the National Heart Center in Singapore. And I'm here together with Prof. Ko, who will co-chair this session. Without too early?
Stand one more time.
Okay, so we are Eric and all the panelists. Nice to see you all. We are live to the Singapore National Heart Center's cath lab. But before we start, I'd like to introduce all our panel members, stellar group of faculty with us. We have Dr. Ko Wen-Yi from Xi'an, China, one of the very experienced interventionists. Very glad that she is able to join us from China. Dr. Ho Hee-Hwa is one of the co-directors with us. Again, the director of the interventional cardiology at An Tok Seng. Dr. Hong Miao Ki, again, been with us for a long time from Korea. Very experienced imaging and physiology assessment. Adrian, all of us know another of our co-directors. Excellent. There's a lot of wide interest. Please stay for his very special case tomorrow that he will be transmitting to us from the National University Heart Center. Dr. Munawa, again, well known not only in PCI, but equally versatile in EP. So from Jakarta. So and Benji Lim from Changi General Hospital is our chat moderator. Is also another experienced interventionist. So without further ado, we will move to the lab now. Aaron Wong, can you hear us?
Yes, we can hear you. We can hear you.
Okay.
Yeah. Hi, good afternoon. So this afternoon we have a fairly complex and interesting case. Can Yann with me is my colleague here in our center. So can you help present the case?
Okay, thank you very much, Prof. Wong. This is an 83-year-old gentleman. He has full house cardiovascular risk factors, smoking, hypertension, hyperlipidemia, and diabetes. He's also got a remote history of cancer. From a cardiac perspective, he's got a history of aortic stenosis. He progressed to have severe aortic stenosis in November 2012. Mild aortic regurgitation, preserved left ventricular ejection fraction. So as part of the pre-valve intervention workup, he underwent a coronary angiogram about a week ago, and that angiogram showed triple vessel disease. The heart team has already discussed, and the consensus is that for PCI first, followed by TAVR in the near future. The next slide will show you his lab investigations. Hemoglobin of 10.2 that has been stable, normal renal function. We have a summary of his current medications, and I'd like to highlight the angiogram in the next slide. So he has a separate ostium of the circumflex and the LAD, and the target lesion today is this very tight mid-LAD heavily calcified stenosis with aneurysmal or dilatation proximal to it. The right coronary artery has a sort of eccentric lesion in the proximal RCA. And on the AP cranial view, you can appreciate there are two tandem lesions in the RPAV. So in summary, we have an 83-year-old gentleman, severe aortic stenosis, and triple vessel disease. I'll hand over to Prof. Wong to describe our progress.
Okay, so I'll just show you the this patient's angiogram today. We go for femoral approach because he's 84 years old, so the subclavian may be a bit tortuous, so radial intervention may be a bit more difficult and may be time consuming for the live case. Yeah. So you can see the angiogram previously presented is a very calcified, because of calcification with the aortic stenosis as well as the coronary artery. So the question is that the patient had quite severe AS, and any sort of complication during the procedures will have impact on the outcome. Because of the AS lah. So So there is RCA lesions and also the LED lesion. So today we try to do the LED first. If we can finish early, then we will proceed to the RCA as well as a bonus. Yeah. The LED is on the angiogram is quite severely calcified, and some of the calcium look very deep. Actually, it's outside the vessel. So we try very hard not to do any atherectomy for this patient because risk of no reflow, and with severe AS, the complication is quite serious. So I'm going to do just balloon-based therapy in this patient. Prof, you want to just have the panel to discuss what's the options here for the LED for now, and then I just let you know what we have done. And Prof, call?
Sure. Eric, you want to?
Yes, sorry, because my introduction was abort because I didn't know that I was already talking during the introduction. Yeah, that's a nice case, and it's a whole philosophy of how treating this patient. Do we have to go for TAVR first or the coronaries afterwards? But I think that's another point of discussion. Let's stick to the technicity of the intervention. Of course, the major risk, everybody agrees with that, is to get in the vicious circle of ischemia, ongoing ischemia in a severe aortic stenosis. That may be a very delicate situation. So I think indeed, if I have to give my proper point of view, it's difficult to see the calcium from here. But I think, yeah, shockwave, if possible, of course, if the lesion doesn't look that critical, so it should be probably possible to do that. Although we have been disappointed in shockwave therapy here in our center, probably very important to size the balloon of the shockwave correct to the vessel size. That's the only thing I would say at this stage, Prof. Ko.
Thank you. Adrian, you think we should rotablate? This one looks very calcified.
Yeah, and I think I share the same concerns with Aaron that given his severe aortic stenosis, slow flow, no reflow would really be very detrimental to the patient. So like Aaron, I think it's wise to just start off with a balloon-based approach. The only caveat is whether the balloon can cross, and we're considering the lithotripsy. I think that would be a major consideration. And if we're forced to use an ablative strategy, then possibly maybe orbital atherectomy might have a lower incidence of distal embolization.
Would anyone consider doing a intravascular imaging to see whether the calcium actually is deep or superficial?
That's probably a good idea. But from my view here, of course, it's difficult to see, but it doesn't look that critical. So I think should be. Of course, it would be a good thing to try and cross with the imaging, because then shockwave balloon will certainly cross. So that may be an option to consider. Yeah.
So Aaron, you heard that? Do any imaging?
Oh yes, we decided to use the OCT because it's at better defining the calcium, the amount of calcium, and also the depth of the calcium. So we have Dr. Yang here with us. So actually, we wired it, and then the OCT went down very easily. We use a guide liner because they're two separate ostium, so the injection may not be adequate for the run. So that's why we just engage the guide liner just at the ostium. As you can see, there's a lesion at the proximal LED. So we try not to injure that part. We try not to stent it. Yeah. So the OCT passed very easily down. Yeah. So I'll show you the first image. Yeah.
It's a new OpStar, Aaron. It's a new.
Yeah. This is the OpStar. Yeah. OpStar. Yes.
Yeah. So if we can show the OCT on the screen. Yes,
okay. Can you hear Chia?
It's much more crossable. Okay, so this was.
I can't hear you.
Yeah, this was a telescope guide extension catheter, I believe, not a guide liner. So we'll go from proximal to distal. I just want to highlight here. This is in a cross-sectional screen in the top right-hand corner. This is of course the OCT catheter. We can see the lumen outside, but actually within this segment, the OCT catheter is still inside the telescope. So this brighter signal over here is the very distal tip of the telescope micro guide extension catheter. So OCT can penetrate the distal 1 to 2 millimeters of the guide extension catheter. So it's very useful in situations like this where there's a bit of osteal disease. You want to assess it, but you don't want to injure it with your guide catheter. So anyway, so moving distally now from proximal, this is the osteal LAD. Some disease there, as we saw angiographically. This is the ectatic or aneurysmal segment in the very proximal LAD. Already we see a little bit of calcium around in the wall. Here we start to get into the disease proper, and again there's a mixture of fibrocalcific, mostly quite a lot of calcium actually around the lumen. In some instances, this is very tight. In some instances, it is circumferential, such as here. It's mostly superficial calcium. In some areas, it is thicker than 0.5 millimeters. And obviously, it's quite a long segment. And this is the mid-LAD where there's some fibrous plaque, but it's probably going to be our landing zone. So in summary, for this pre-PCI assessment by OCT, it's a long, diffusely diseased lesion with quite a bit of calcium. If we use the OCT calcium score, we're going to get full marks, full points from the calcium score. So calcium score, just for revision, is calcium thickness maximum calcium thickness more than 500 microns, length of calcium more than 5 millimeters, and arc of calcium more than 180 degrees. And if you have all three criteria, then it is a predictor of poor stent expansion. So you might want to consider using adjunctive calcium modification techniques. So that's the pre-PCI OCT.
Remember, it's rule of 5, right? Yeah.
That's right, 555. Yeah, 5 millimeters, 0.5 half circumference. That's half circumference, so that's 180 degrees, and then the 500 microns thickness.
That's great. The view with the telescope is nice. I didn't know that you could basically look through the distal part of the telescope into the black. That's nice.
Yep.
So that sounds good for survey.
Get a comment from LP. Yeah.
First of all, in this educational cases, this is a really educational case. We have the suspect that the angiographic appearance is really the severe calcification. Using the OCT, we can clearly demonstrate the severity of the calcium, particularly in the superficially. So based on the OCT finding, we can more clearly establish our next treatment plan. That is the very strong message to every interventionist. Use the imaging before the PCI.
Okay, Aaron, you like to proceed?
Yep. So we saw the OCT, and then we thought there was angiographically and also on the OCT the calcification is quite bad. So anyway, we like I mentioned before, we try not to use atherectomy for this case, and it's quite deep. And even if we did, the bird did go through, the result may not be optimal because of the deep calcium. So we use a 2.5 NC balloon to pre-dilate it. So initially, the distal part beyond the diagonal, the dilatation is quite well expanded. And we thought the proximal part, there's a waist there. So we use a 3.0 NC balloon to dilate. As you can see, there is a waist at that part there, just before the diagonal. Yeah. So
how much pressure did you apply?
I went out to 24 actually.
Okay. Not all NC balloons would support that, huh? Not all brands.
Yeah. So this is an NC track NC balloon. So it's quite at 24 it never ruptured. Yeah, but it's still that there's a waist there. Just back to the panel, see what sort of what options you're going to use. OPN, IVL, rotablade, atherectomy. Yeah, on this view you can see the calcium below the balloon. Yeah.
Well, I think
Dr.
everybody will.
Nawa,
Yeah.
you have IVLs?
No, we don't have
Indonesia?
IVL actually, and it's not available in Jakarta. But for this kind of situation, might be I do with the cutting balloon. Cutting balloon can crack the calcium more rather than just doing with NC balloon. Then after that, yeah, of course we do with the big balloon because cutting balloon available in Jakarta is only 3.25.
Are you not concerned about damaging the blades of cutting? Because how much pressure do you use in the cutting? Because we
no, the cutting balloon usually we use 6, 10, and then sometimes if still no waste, still waste appear there, then I increasing until maybe 18 or maybe 20. I agree with the use of the cutting balloon in this kind of situation. The issue is what size of the cutting balloon. Actually, I'd like to ask, why did you use the first 2.5, the non-compliance balloon? The selection of the balloon should be at the imaging basis. Actually, the vessel size was in my view, more than a 3.0. So they initially try to do the PCI with a 3.0 non-compliance balloon. If there is some indentation or not fully dilated, and then we will have the next plan. So anyhow, in this kind of situation, I agree with the Manoa's suggestion. Cutting balloon is a good suggestion, and the next issue is what size of the cutting balloon to relieve the indentation.
As teaching this, maybe
I would be concerned a bit about cutting balloon because I know people go to high pressure, and I have seen trouble with the blades. The only issue is today IVL is so easy to use. Of course, if you don't have it in your lab, it's a problem. But I don't know why we shouldn't use it, because it's potentially a little bit more effective and safer. I don't know, Prof. Ko, what do you think?
Yeah, we do use it quite commonly, the cutting balloons, but obviously you need to be very careful because once it ruptures, the calcified lesions might be extremely difficult to get it back.
Yeah.
Aaron,
but what you have to do is, what we have to do for cutting balloon is that increasing is very carefully. I mean, that's, it's not like NC balloon or something like that, but we have to be, smoothly to increasing the pressure. That's the point.
So this is after the 3.0 NC balloon. It looks like still not well dilated. So I'm a fan of OPN. So in this case, I choose a smaller size, 2.5, just in case that because on the initial comment that the artery looks like 3.0 now, but before when we did the first OCT, when we measured the distal, is only about 2.5 actually. Yeah. So anyway, OPN we go up to actually 40 atmosphere, and then it never budged at all. Yeah. So we decided to use IVL. We chose a 3.0. Yeah. Sorry.
Yes, maybe if you have time, because I saw you're already on the right. You want to comment a little bit on the OPN? Aaron, we use it also quite often, but there are some tips and tricks not to. I also don't mind to go to 40, but you have some tips and tricks on the use of OPN balloon.
Yes,
maybe you can ask Dr. Kwok. Dr. Kwok, does it do? When do you do OPNs? Is it available in China?
Yeah, sometimes in this kind of very calcified lesion, we sometimes try to use cutting balloon or scoring balloon, maybe safer than this. So because the OCT show us the lot of calcified node in there, so it's quite difficult to open fully. So after the cutting balloon or scoring balloon, and then we use the NC balloon.
Mm-hmm. Thank you.
So Aaron, what tricks you have for us?
For the OPN, there's not much trick. The only thing that you make sure that you size the balloon. Imaging is preferred because you can size the vessel correctly. Then you never size it more than the vessels. Actually, I tend to undersize it because of the calcium, the plug inside. You may the actual size of the vessel may be big, but the lumen is small. So rarely that it perforate, but saying that I just had one case which had a perforation, maybe a bit too greedy with the balloon size, yeah. So just size it 1:1, and then can go high pressure 35. They recommend is 35, but sometimes go up to 30 or 40. Yeah.
So you need to use a special inflation device.
Yes,
I can
correct.
that while you're working. I can say that. And one maybe important message for OPN: it is not compatible with the series of all wires. So Sion wire family is not compatible with OPN balloon. So if you inflate to more than 30 atmosphere, the balloon will basically stick on the wire, and it will be impossible to pull out the balloon. So you should use other wires if you use OPN balloon. I think this is an important message. I've been several times to, mostly I go to 40 also, Aaron, but I have had ruptures of OPN balloons, and it's mostly the inner balloon that will rupture. Although I also had complete rupture, and I had a few perforations indeed. Yeah.
Oh, that's nice to know. What about run-throughs? We use it very frequently. Any issues with that? Run-through with the remote wire?
I don't use.
30分钟，半个小时。
So which wire, Dr. Hao? You usually use?
You cannot use OPN with the family of Sion wires, which all my young guys use only Sion blue and Sion wire. So if you put the OPN on the Sion wire, you will get in trouble. Don't do it.
I think one way to overcome that is usually is to put a body wire. So because
you put a body wire,
yeah. So because if there's a chance of you pulling out the wire, at least you have one extra wire in case something bad happens. So for OPN, I tend to undersize and I go very high pressure because I'm very fearful of perforation.
But now that we have shockwave, we use much less.
What about Benji? Benji, you used to work in Bern, right? They use a lot of OPN there. We use.
Yes, Prof. I did my fellowship there. That was before the shockwave, and yeah, we did use quite a few OPNs.
The hand. It's a hand there.
Patient's hand.
Keep falling off. Not here.
So Adrian, you think we should go ahead with the IVL here, or we should?
Yeah, personally, if it's available, I would prefer to use IVL. It's I think more controlled and it's more predictable.
So if we need to use IVL, in this case, should you actually like dilate until like what Aaron did, size up to the vessel size, or you just pre-dilate a little bit? Does it make a difference in terms of cracking the calcium?
Usually, I'll just make sure that I've dilated enough so that the IVL balloon can cross, and I would actually size the IVL with intravascular imaging. And I find that if you go beyond the usual 4 to 6 atmosphere, just make sure you get apposition of the balloon. It does actually help with the effectiveness of the IVL.
The point with IVL, I fully agree with you. We also tend to prepare a bit the lesion with NC balloons before getting the IVL in. Anyway, this procedure is costly, so one more balloon or less balloon doesn't make a difference. Is there any reason why you use biplane, Aaron? I think it's nice to work in biplane, basically.
Oh, we have 2 biplanes room here, so.
If you're in femoral, I also work in biplane because it's just nicer. Yeah, it's fun.
Yeah. So anyway, so we use a IVL 330. What's the length? 12. 3/12. And As you can see here, we go out for about almost 50 shots. This is before the IVL. A lot of dissection there. This is the IVL balloon. We went out there and it looks like it's not expanding like what we like to, with the magical expansion of the calcified lesion. So a little bit disappointed, but sometimes it crack the lesion but not expand the lesion. So the further post dilatation with the NC balloon may crack it, So we used about 70 shots. We thought that it wasn't not going to do anything here. So what's next? Any suggestion, panel?
I think we have the same frustration quite often, Aaron, with IVL. You're doing it and you remain frustrated, but you probably can try to go back with OPN, huh? Probably, or do some imaging to see if something changed. But
so we see that. Actually, we didn't do the imaging because we thought that it didn't crack at all. Anyway, there was a lot of dissection there. You can't tell where is it from. So we just use a 3O NC balloon, and it looks like after the IVL, it appears expansion is better. Yeah. So this is a two, and then we do an OCT. Yeah. So Chiang can comment on the thing. Yeah.
All right. So if we go back to the OCT. Okay. Now let's go from distal to proximal. So this is the distal part of the vessel. Here you see a little bit of a dissection that's caused by our balloon. Here's a chunk of eccentric calcium that was there before. You can see that most of the balloon dilatation caused dissections on the opposite side of the calcium rather than through the calcium itself. That's what we often see. So going more proximally, what we're hoping to see obviously is cracks within the calcium itself. Perhaps something like here in this segment over here, there seems to be a crack going right through the calcium chunk. Going more proximally again, you'll still see a crack over here, which is nice to see. These dissections seem to be going through the intima or media layer around the calcium rather than through the calcium. That's the diagonal wire joining in. So again, some tears here and there. This is certainly a vessel that's undergone a lot of balloon dilatation. Here is the proximal segment. Again, a little bit of dissection extending beyond the area of balloon dilatation. So sometimes it's hard to know whether some of these cracks or dissections are caused by the shock wave or not, because there was a lot of other ballooning involved. But certainly there's evidence of quite a lot of dissections, some cracks in the calcium plate as well. So I think,
so with that, we're quite confident that even though it may not expand fully, but for this 84-year-old gentleman, I think it's good enough for him. So we just do a small pre-dilation to the diagonal branch, and we put implant the 3O28. We just try to land it just at the neck of that ectatic segment. We position it. And then this is the expansion. As you can see, the proximal part is still not well expanded. After that, we use a 3.5 NC balloon, and it can see that the expansion is much better now. And we use a stent boost to visualize the expansion of the stent. And then it looks like the proximal part of the stent is quite well expanded. Yeah. Anyway, this is a 3.5 NC. This is 3.0 NC, post-dilate the distal part. And then we did another OCT before we use a 4.0 to dilate the proximal part. Yeah, okay. Chia?
Okay, I'm just gonna present this OCT first, if that's okay. So this is the OCT taken after post dilatation of the stent. Now that the vessel has been enlarged, it's a large vessel, so the blood clearance is not so good. So this OCT quality is not the best. Apologize for that. That's the best that we could do. So it's the distal segment. I'm just gonna turn off the rendered stent. Yeah, the stent looks pretty well posed here. No obvious edge dissections distally. We're going proximally now. The other area of interest is the proximal stent edge. We can see that there's some malapposition, which we expect because it's an ectatic segment. With the OCT integrated software, obviously it tells us automatically whether there's malapposition or not. If your pullback is very good, that's very reliable. But our blood clearance in this particular example is not great, so I'm not going to rely on the any of the automated functions because they may be erroneous. So this is, yeah, a little bit of malapposition here. I think Aaron wasn't completely pleased about this, so he went ahead to post-dilate a little bit more with a slightly larger balloon.
Okay, so also on the angiographic view on when we do the pullback of the OCT, it looks like angiographically looks quite acceptable as well with the expansion. Yeah, so I post-dilated with the 4.0 short 4.0 balloon at the proximal part. And then this is a final angiographic picture of the LAD. So I think the, not perfect, but I think the lumen size is big enough.
It's fantastic,
I mean,
Aaron.
yeah.
It's fantastic. How far do you go? Because on OCT, there is always some malapposition, so you can continue forever. Sometimes I have the impression when you image it. I don't know. What is your feeling about that?
I mean, how? Yeah, I mean, a little bit of malposition. I think it's acceptable, but I mean, in this case, I'm just a bit paranoid, but especially when it's inside the big ectatic segment. So I just use a 4.0 short 4.0, just one dilatation. That's all.
Any comments? It looks fantastic when you see when you came from the panelists.
Yeah, any panelists like to add on?
Maybe we can ask Professor Hong from Korea what he thinks about the final result.
Actually, personally, I think the angiographic and the OCT find is quite successful. It's a very happy result. And even though there is a small size of the malposition in the large vessel segment, but it is almost to be negligible. Don't worry about that. Usually, even though there is some malposition, clinical outcome is really, really benign. Please believe it. Believe me. Don't worry. And second one is this is one of the very educational finding is the OCT image run after the shock wave and the non-compliance balloon angioplasty. When I look at the OCT finding, multiple dissection. Personally, even though I don't have experience of the shock wave, but a lot of the dissection and clot made by the shock wave, not only for the non-compliance balloon. So I think the use of the shock wave in this patient is really effective. And such finding was clearly shown to the audience with the OCT examination. That is my comment.
Fully agree. Thank you very much.
Sorry to interrupt. There are a couple of questions from the audience. The first question was, would not biplane increase the radiation? And another question was, would you like to balloon the side branch?
I think if you see you're using the protection cage from Microport, Aaron, I see that. Is it correct? Because it's difficult to see from here. But do you use the protection?
We have the shield here. I mean, we always have the leg shield here with us for even biplane, single plane, we don't have it. And so I think it's more, but biplane is more convenient that you don't have to keep swinging the lap. But when we do cine and things like that, if we don't require biplane, we switch off one of the plane to save radiation. And also with the Philips system, we can adjust the radiation dose to really low. Even a long CTO procedures, the radiation dose can be cut down quite a lot. Yeah.
Radiation is not an issue with in the Philips, no. Really.
Yeah. In our Asian patients, our body size is much smaller, so we can usually go with a low fluoro 7.5 frames easily. most times can visualize quite clearly. So that will be helpful in cutting down the radiation. And also, I tend to see at the 7.5 frames during this diagnostic meet.
And I think the biplane is also good to just check the balloon expansion during your pre-dilatation phase, just to make sure it's expanding in all angulations.
Yeah, because sometimes the lesion could be eccentric. Certain view could be expanded quite well. The other may not be. Yeah. Anyhow, to answer the other question, I did pre-dilate the diagonal branch, but the flow looks fine. So I don't think I will go and do a kissing for that. Oh. So actually, the main case is for this LAD. But I think for this case, it's quite interesting that the theme for this what we call this session is a calcified nodules. So actually, I actually want to finish this LAD quickly so that we can show you some OCT of the RCA, which on the angiogram, which if you can recall from the presentation, indeed had the eccentric sort of calcium at the proximal RCA. So we're going to treat this the RCA lesion anyhow. Patient a bit restless, so we will just may have to quickly finish the procedures for him. So I just need an OCT. So maybe Chiang can comment on the thing when we may not be able to finish it live in this case, but I think we have some point to discuss what is the treatment option for this calcified nodule.
This is the OCT for the RCA. If you probably saw on the angio, it looked like an eccentric calcific lesion. We wondered if it was a calcified nodule angiographically. But on OCT, here we come to the area which is tight. So you can see calcium, which is the low signal lesion inside the wall of the intima. But apart from that, there isn't the typical features of a calcified nodule. So for calcified nodules, often you have these little nodular calcifications which also protrude into the lumen. They're usually superimposed with thrombus or fibrin, and which then cause some kind of signal attenuation. But we don't see any of that in this case. So I don't think by imaging this qualifies to be called a calcified nodule. This is probably just an eccentric. In fact, in some areas it is concentric. It's probably just a calcified lesion rather than a calcified nodule by imaging definitions. I'm not sure if any of the other panelists, like Dr. Hong, wants to comment on this.
I agree with your comment.
Mm-hmm. So, so you think that we should treat this as a normal calcium, as a sort of calcification, yeah, not a nodule, but it does look very eccentric though. Yeah.
On angio, it looks eccentric. On imaging, there are areas where it's quite concentric. So, in fact, it's almost all concentric in the tightest areas.
So we could ask our colleagues who are in front of cutting balloon if cutting balloon would add some value here. Maybe you can ask Dr. Miravar if you would use cutting balloon again here.
Well, because yeah, I saw that the calcium is in the superficial, more superficial, and this is quite big. So I'm not doing, you know, if I have a rota, I do rota first. Sometimes combination with rota and cutting balloon. So I do with the 1.75, maybe 2. Then if still, you know, cannot crack, then using cutting balloon.
But the problem here in this patient, he has aortic stenosis, doing rota in the right. If you get into bradycardia, that would be very troublesome.
Yeah. So
be very concerned. Yeah.
So we have to be careful. Yes, I agree with that.
The other comment is
in the right. My last rota in the right, the patient arrested. So flat line. So it happens quite often.
The other comment that Adrian made while we are reviewing this case is that if you get slow flow, no reflow, that's a major problem with the severe AS. So we need to be very careful.
If to come back to the biplane, Prof, I think here the biplane is very useful also for the right, because the lateral view for the right is very nice. You see, you have a very nice view on the right. We see it very nicely on this on this live case, the usefulness of biplane for intervention in the RCA. So what are you doing now? Sorry, let you speak.
Yeah, sorry. I guess Aaron's probably going to do the same PCI strategy as the LAD. I don't know about the experience for IVR for eccentric calcium, because there seems to be quite positive data recently from Zaid Ali's analysis. So I don't know what's everybody's experience like for eccentric calcium.
Maybe Adrian, what's your experience? You do many of these eccentric nodules.
Yeah, it's always a challenge, eccentric nodules, and one of the reasons why I'm not in this case because of the aortic stenosis. When in patients who doesn't have concomitant aortic stenosis, one of the advantages of orbital atherectomy is to try and see if you can actually use the pullback technique because of the eccentric position of the nodule to have selective actually atheroablation in those situations. But in this case where on intravascular imaging, it does appear to be quite circumferential, I think cutting balloon or lithotripsy would be a good option in this case here. Besides the usual non-compliant balloon.
So, Adrian, so if hypothetically, if you think that atherectomy is really needed, let's say in this case, patient with severe AS, would you consider putting in a IABP in advance or not? I mean, if you really need to do atherectomy.
What's the vessel size?
I think if you really have no choice, following a very extensive discussion with the patient, then you may want to consider, the left ventricular support. Yeah, but by and large, I think generally very old patients, and at least in our hospital, would not actually fulfill criteria for use of the impeller, because we generally only use the impeller in patients who have an option of ECMO or heart transplant.
This is a tree.
So the IBP possible, but again, much of the evidence is quite empirical. There isn't a lot of strong evidence for using impeller.
Maybe you can just ask Dr. Guo, what's your experience after we stent this eccentric nodular-like lesions? What's your long-term outcomes, you think?
Because we don't have a lot of things can use, just like the in this time, this is the first time I see the IVL shock wave in the human. So we just can use the cutting balloon or rotablator or scoring balloon or the NC balloon to modify the lesion. So we don't have a lot of experience for so many different technique to modify the lesion. So most patients just like this, we still try to use the normally things and open if found, and then try to transfer the rotablator or cutting balloon again and again to show the lesion change. Mostly we can do it well, and can open the lesion.
In my view, the treatment of the eccentric calcific nodule or calcium is not easy, because how do we fix it effectively, selectively, or exclusively? The rotablation, it is not easy. Even though we did the high pressure cutting balloon or non-compliance balloon, the there is the more injury to the in the counterlateral the normal segment. So after the treating of the eccentric calcium, and then we do the imaging, the cross-sectional view was almost very eccentric, the lumen area. So at that time, how do we to improve the clinical outcome is just to gain the more larger stent lumen area, the next alternative step. Very eccentric appearance and the very small stent lumen area, the patient prognosis might be maybe not good. So therefore, alternatively try to gain the larger stent lumen areas at another alternative step.
Sometimes we can use laser to modify the lesion. Sometimes it's effective.
How do you do that?
Just use the laser wire in and try to modify the nodule calcified.
Modification of the calcified nodule, but the same kind of the injury is the contralateral segment without the severe calcium. So it creates another complication in the relatively normal segment. There is the risk.
The laser is not very. I think we need to get back to Aaron. Aaron, how are you?
Yes. So what? Thank you for letting me work on this RCA. So actually, there is 3 lesions here. One is the distal, just after the one of the branch, and then one is the PL branch. But the PL branch look very calcified. The lesion a bit difficult to wire. I think the patient a bit restless. So I think I would just fix the distal RCA plus the proximal part. I think that's probably good for him. So the distal part a little bit difficult to cross with a 2.5 with 2.05 cross, and then we use a 2.5 NC, and then we use a 3.0 NC, put the guideliner down, and then we put the stent down, and then this is after pre-dilatation with a 3.5 NC balloon of the proximal part, and we deploy the stent distally. We haven't done the CNI yet. Yeah, 好了 okay. Yeah. So I'm going to use a 4.0 to dilate the proximal part and stent it post-dilate, and we will end the procedures. Patients getting quite restless. Yeah.
4.15.
Yeah.
I can imagine. Do you also always have a geriatrician involved in the team heart team approach? Because of course it's an important point before embarking in a project of TAVI and PCI before. I don't know. Maybe you can ask the panelists. So in your valve team, in your valve board, do you also always have the advice of the geriatric on the frailty and seeing, because if the geriatrics tell us that this is no go, we don't go for TAVI.
You can put 3.5 and post dilate.
I think that's a good point, Eric. Unfortunately, I think in most institutions in Singapore, we don't have enough geriatricians around that can sit in on the heart team. But I agree absolutely with you that we're not very good in assessing frailty, and sometimes you have this really very sick elderly patients. I'm not sure how much benefit we are doing them by sending them for all these very complex procedures. Yeah, but it's an excellent point whether geriatricians should be more involved.
Yeah, they see all our patients basically, and if they say no, we don't go for that. Sometimes we don't understand them because we think the patient is fit and looking well, but they have another view on the patient. Because the prognosis of, if a guy can't walk 10 meters, then you shouldn't go for a TAVI because he can't walk, not because of his TAVI, but because he's old and frail. Yeah. That's important to realize.
Maybe you can ask if Dr. Jin Jiang is still around. What are the issues about the calcified nodule, in terms of the intervention and follow-up?
Yeah, Prof. Thanks. So I think the problem with calcified nodules and getting a good PCI result is, I guess, similar to any kind of lesion where you only have eccentric calcium. It's very difficult to prepare these lesions because, as has been mentioned also by the other panelists, when you balloon a lesion that has eccentric calcification, usually, nothing much happens to the calcium, but the opposite wall is the one that gets dissected. So with the calcified nodule also, the calcification extends into the lumen, and that further compromises the lumen size and makes it very difficult to get a nice expansion of your stent thereafter. So I think calcified nodules definitely are very difficult to treat, difficult to get a nice PCI or stent result. There's a lot of debate about whether about what is the best way to modify or best way to treat these calcified nodules, whether it's atherectomy or shockwave. I think the jury's still out on that. So certainly it's very, very difficult kind of lesion to tackle.
But actually, they have quite a high chance of having restenosis compared to more concentric kind of lesions, as well as stent thrombosis. The rate seems to be higher in this kind of really calcified nodule. Not in this case, but I mean, if it's a real calcified nodule with hemorrhage and sort of plaques.
I think we don't have that much really systematic data on that subject, Prof. Ko. It would be nice to have a kind of registry on calcified nodules. And first, if you want to do that, you have to define what is a calcified nodule, because otherwise it will be a mixed bag of cases. But if we all have experience with that, with variable outcomes. But yeah, if you want to really know, you should have more consistent data.
Yeah, I think there are no randomized trials, but I think there are a couple of registries which tend to reflect some of these issues.
Yeah.
So there's also like some risk of stent malapposition after you implant stent.
So how much time do we have left, Prof. Ko? If you think getting to the end.
I think we got like 5 minutes left, so maybe we can ask Aaron.
Prof. So as you can see, I stent the distal and then use a 4O to pre-dilate the proximal part, and then we place a 3.5 stent, which this platform can go up to about 5.5 actually. So not to worry about undersizing. So we implant it, and then we use a 4O NC balloon. As you can see, this is a shot after the stent placement. There is still a waste at the where the calcified nodule, not calcified nodule, eccentric thing is. But if you look at the other view, actually it's quite fairly well expanded actually. So it's an eccentric calcification, I think. Yeah. So
okay,
I'm
Aaron,
just quickly do an OCT before we go off. Yep.
No, Aaron, we run out of time, so we have to conclude here.
Sure, no problem.
Yeah. Anyway, it's a nice demonstration. I'd like to take this opportunity to thank Eric and the rest of the panelists for this very nice, interesting, and informative case teaching us about eccentric calcium and calcified lesions. Thank you all very much. We have to close here, so we hope to see you soon in a couple of minutes. Yeah, thank you all.
Thank you, Prof. Ko. Thank you.
Thank you.
Thanks, everyone.
Thanks.